please. Thank you. Good morning, good afternoon, good evening, everyone, and wherever you are. And welcome to this third virtual and TechNet webinar series on why gender matters for immunization. The session today is about integrating services and collaborating across sectors. You can listen to this session in French. To do so, please click on the globe icon that is at the bottom of your Zoom window and select the language in which you'd like to listen to this session. And now in French, just quickly for our francophone audience. Bonjour, vous pouvez écouter cette session en français. Pour ce faire, veuillez cliquer sur l'icône en forme de globe qui est en bas de votre écran et sélectionner la langue dans laquelle vous souhaitez écouter cette session. We will also present this session with French slides. So you can now watch the slides in French. What you need to do is select View option, click on View option at the bottom of your window and select Alexandre Pascuto, my name, to see the French slide. I'm going to say that in French as well for our francophone audience. Vous pouvez aussi voir la présentation visuelle en français. Pour ce faire, veuillez cliquer sur option visuelle et choisissez qui se trouve en fait à en haut de votre écran et choisissez mon nom pour pouvoir voir la présentation en français et choisissez Michaela Mann pour la présentation en anglais. We'd be happy to know who's with us today, so please, you can already introduce yourselves in the chat box and tell us your name and where you're from. You can also use the chat box if you need any technical support. I will do my best to help you. If you have any questions during the presentation, please use the Q&A box. It's available at the bottom of your Zoom window. You can ask your questions at any time. Our panelists will answer the questions after the presentation during the Q&A session. Finally, this session is, as usual, recorded. We will share with you the links to the video as well as the slides by email later next week, probably. I hope you'll enjoy this session, and I'll give the floor to Michaela, I think. Thank you.
Thanks so much, Alex, and welcome, everybody. Welcome to the third webinar of this second webinar series on why gender matters for immunization. We hope you were able to join the previous series that we organized last year, as well as the previous webinar to this one. And we hope you're familiar by now with the guidance document, Why Gender Matters for Immunization, Immunization Agenda 2030. If you missed the previous webinars, don't worry, because as you know, you can find all the recordings, all the materials in the TechNet webpage, as Alex just mentioned. There are still 2 webinars in this webinar series. So if you're registered to this webinar, you're automatically registered to the following ones. So we hope you can join us, but still continue to share the registration link as well as all the materials with your network and colleagues. Today we are going to discuss about the importance of integrated services and collaboration across sectors. This is one of the gender-responsive approaches to increasing immunization coverage, as outlined in the Why Gender Matters for Immunization guidance. Today we will have 2 topics, 2 presentations, and 4 guests with us. So we will have Kavi Amsambat, who is a social and behavior change specialist from UNICEF, Lao. We will have Maria Lemos, who is a gender consultant, who is from UNICEF Lao country office. And then with them, there will be Dr. Shukrat Rakimjanov will be support them with any questions that you might have. And then we will have Tendai Gudo, who is the country director of the Apostolic Women Empowerment Trust from Zimbabwe. I think we are also, by now you're familiar on why gender matters for immunization, but still very important to reiterate that gender impacts immunization both on the demand side through people health seeking behavior, as well as the supply side through the provision of health services. And so if we want to increase immunization coverage, it's really important that we understand and address the many ways in which gender interacts with additional factors such as socioeconomic, geographic, and cultural factors to influence the access, uptake, and delivery of vaccines. As mentioned, the guide Why Gender Matters has outlines a number of gender responsive approaches to increase immunization coverage. We already covered many of them. And as mentioned today, we're going to focus on integrated services and collaboration across sectors. And we're focused on this topic because establishing linkages with other health and also non-health intervention can improve immunization coverage and at the same time advance gender equality. So immunization programs can also be strong entry points to increase access to other primary healthcare services and education, while at the same time transforming harmful gender norms and roles. And we have two very interesting examples today that really show how this is implemented and how this is possible. So partnership with other health programs can contribute to decreasing maternal mortality and morbidity rates and advance also reproductive health rights, and as well as the access to education. So in the guide, you, as always, you have a list, an action list on how you can, with concrete action that you can implement to implement gender responsive integration. I won't read through all of them, but I really invite you to go through the guide and really go through these actions and see how you can also adapt to your context. So with that, I'll hand over to our first speaker. Kavi, over to you.
Hi, good afternoon, everyone. Good evening here from Lao PDR as well. I am right now based in Sieng Khouang province in the northern parts of Laos. So my name is Kavi. I am social behavior change specialist at the UNICEF Lao PDR. So today we are happy to be invited to present about the cross-sectoral works that we are working with the mass organization here called Lao Women Unions. And today we're going to be presenting three different areas. Number one is the context of immunization here in Laos, and then how we work cross-sectoral with Lao Women Unions and other ministry to enhance the gender in immunization, and the work that we are working to enhance the early childhood developments. And then our colleague Maria is going to be sharing the situation on the gender analysis of immunization. Can we have the next slide, please? Thank you. So my connection is not very good, but if I don't have the video, I apologize as well. So I'm trying my best to connect. Over the past 3 years, the improvement rate of the immunization in Lao PDR has increased significantly. So as you can see here on the screen, from 2021 to 2023, we have seen a significant improvement in immunization rate across the country. So the number of the district with lower immunization rate, as you can see in red colors, has decreased. So on the other hand, the number of districts with immunization rate above 90%, as you can see here in the dark green, has increased from 64 to 84%. Still, in some areas of the capital city, there is still some district that is remain below 50% on immunization coverage. As you can see here, the color is indicated red. So over the past year, the method that we have been doing to deliver immunization service that is actually proven to be super effective through the three area, the improvement of the health facilities, a significant effort in the outreach services, and then the mobile service where we have people on the ground visiting household and conduct mobile and vaccination on site. So can we have the next slide, please? So just take a look at the situations in Laos in general. So in Lao PDR, Laos is the country in Southeast Asia. So it's a very diverse country with over 50 ethnic groups. So even though women have equal rights by law, some traditions and customs often prevent these rights from being fully practiced. Child marriage and adolescent pregnancy are common. So 31% of girls marry before 18 and 17 give birth before 18. So literacy rates show 80% of young women and 40% of young men aged between 15 to 24 are illiterate. So many adolescents are out of school, especially girls, with 58% of upper secondary school age adolescents not attending school. So in the country, women are the main caregivers, while men are decision makers and heads of the household. Next, please. So with that situation that we have, there is a lot of demand within the government to create a program where we can work cost and then the cost sector approach, especially on how we tackle the gender barrier as well as to improve the early childhood development. So before we go into more detail into the parenting program, so I would like to give a little bit of the explanation of the government counterpart that we are working closely to implement this program. So we are working closely with Lao Women Unions. So Lao Women Union is a mass organization under the party of Lao PDR and is quite similar to the ministerial level. So Lao Women Union is the only organization in Lao where all members are women. So we have the member who is the leader from the central level to the provincial and district level, all the way to the village level. So in Lao Women Unions, we have members of the Lao Women Union across all 18 provinces, 140 districts, over 8,000 villages across the country. So the initiative that we are working with Lao Women Union since 2018 is the program called Love and Care for Every Child. It's a program that focuses on social and behavioral change practices. So the goal that we are working with on this particular program is to give information, but not to instruct, but to give the information and then give them key messages so that the community will be able to have the community dialogue and more understanding towards health and well-being of the children so that they will be able to demand for the service. So basically, we are working on the demand side to have the community to demand for services that will help improve the well-being of the children. So it's not just only parents in the community. It's not just only father or mother, but also grandmother and everyone in the community. That's why we say it takes a whole village to raise a children. So basically, in the parenting program, there are three key pillars. So there is a pillar of care, protection, and communication. Because today the topic that we're doing is on gender and immunization. So one of the key area that is very, very important in the parenting program is care. And in the areas of care, there's two areas that we are focusing on. Number one is the ANC, antenatal care for pregnant women, and also the immunization area where we're focusing on providing immunization to children across the countries. So basically, the parenting programs, we're working with Lao Women Union, but also others technical lead ministry as well to provide technical support and also to conduct a community dialogue for the community to demand for health service for the children. And also the area is called protection. So in the protection, we are working on providing the support of the father to understand more about the the role of the father in protecting children, especially his daughter. So there's a lot of early child marriage in Lao PDR, and this protection area we are focusing on increasing knowledge and do the prevention on early marriage, as well as providing support on birth registration. And then the last pillars of the parenting program, we call it communication. So it's actually related to early stimulation and both communication and care support for both parents, especially for husband to take care of the wife while she's pregnant, or the division of the household chores. Next. So this is the slide that just sharing why the parenting program is needed. So basically, it's not just we created this parenting program out of the whim, but there's a lots of research, a lot of background is backing up these developments of the program. So we see that from our LSIS. So LSIS is the research that we have. Is more of the mixed method that is conducting every 5 years. So in 2017, the result from this LSIS research came out that there's a lots of disparity, especially from the urban and the rural areas on early childhood cares and developments. And there's also a demand from the community that need to have more of the social behavior change communication as well as community engagement to discuss what is needed for children, so that there is the demands coming from community to create the service. So there's a demand side, and then the government will be pressure to work in a cross-sectoral approach to provide the service that would fulfill the demands from the community. Next. Can I have next slide, please? So in the parenting program, so there's two areas of support. So number one is technical guidance, and number two we call social mobilization. So Lao Women Union is actually are putting their feet onto like areas. So they're also providing technical guidance as well as mobilizing their own network in each of the community where they have the strong presence at. So in this area, at the moment, we are expanding the parenting program into 14 districts across 6 provinces in Laos. And 2 of the provinces in the north have a lot of issue on early child marriage and also the gender issue, especially the barrier to immunization among certain ethnic group. And that is why the intervention is focusing on for the expansion. Next. So as I mentioned before, there are 3 pillars of the parenting program. And as you can see here, we are not focusing much on providing IEC material, because social behavior change is not just only providing poster and flip chart and also one-way communication, but we are focusing on community dialogues, interpersonal communication, group discussion, and community level engagement, because we believe that when community realize about certain topic, there was still a conversation around it, and then there would be a demand for a certain service that would help fulfill their needs. So that's the reason why we are very human-centered design in the way that we are designing the program. And among these 3 key pillars, we are focusing on community dialogue. Can we have next slide, please? So I just want to share with you, these are the communication materials that we are developing. So this communication material is being validated and developed with the community, for the community. So we have, as I mentioned, we are a very diverse country. We have different ethnic groups and we have different languages. So these communication materials are translated and also adapted into the context that fit the people in the community. Next. So so I would like to share a little bit of the household dynamics here in Lao PDR, especially on some areas on barrier to immunization on the gender areas. So in community, men are the most influential and believe they should make all final decision. And women often lack access to resources like finances, transportation, mobile phone, and driving licenses. So if a child get a fever after vaccination, so mostly father tend to blame the mother, not even though it's a normal side effect. So that's one of the areas why the family didn't want to take children to get vaccination. And more the information in the community. So men often cannot attend information session because they are working in the field during the day. So when they do attend, they tend to dominate most of the conversation. So these are just the fun of the example that we have before the intervention of the parenting program. And this is actually one of the study that we have received from Lao Women Unions and also from their own observation as well. Next. So over the past 4 years, when we are conducting the parenting program, starting from the inception of the program, during the pilot program, and now we're expanding to more locations. So we can share with you some of the example, especially 3 examples that we have here from the program, especially in the areas of gender. So the first one is to engage with the community. So the good example is to share good example, show how father involvement benefits children. So when husbands see good example, they are more likely to follow. So remember, Lao is a very collective society. So if one person see there's a good example from their neighbors, and there's one good example from somebody they know, so they tend to follow. So focusing on creating that good dynamic, on creating that good example and sharing it. So because Lao is a very hierarchical society, so community leaders has most of the power and most of the say, and a lots of people, especially a member of the community, would follow. So it's very important that we engage with the community leaders. In some ethnic groups, it's very important to involve village leader in community dialogues. And in some other areas where women can be a leader, so it's very important that we're focusing on having the engagement with that women leader to start a conversation. Also, with the other example that we already mentioned is to work with Lao Women Union, because they have a very strong presence on the grounds in all the villages. So it's very important that we make use of that network and connection. And some other areas that I would like to share is the implementation evaluation. So in the implementation evaluation, it's very important for us to effectively monitor the progress of the behavioral change, because that is the core of our programs. So we have implemented evaluation during each of the 5 sections. So village committee will play a crucial role in collecting and analyzing data on several key aspects. So for the participation during each session, village committee will count the number of women and men participating, and this will help us understand gender dynamic and ensure inclusive participation. And also the father participation as well. So we have asked specific questions to assess the involvement of the father in various activities. For example, if the father has accompanied his wife to ANC. So this question helps us to understand the level of support father provided during the pregnancy. Especially for the next question that we have as well is the support of the household chores while the wife is pregnant. So this will help us understand who assists with the household chores and highlight the responsibility and support within the household. And other area on the support in the family, especially the development of the children, is the nutrition areas. So we also monitor and ask questions during the home visit if the couple had discussed how to ensure good nutrition for both mother and children. So by collecting and analyzing this data, we monitor behavioral change and adjust our program to better support the community. So this structured approach ensures that we can measure progress, identify area for improvement, and celebrate success in the program. So make sure that there's more dynamic in both father and mother the discussion during the household visit. Next slide, please. So the most important areas of the parenting programs is the area where we call the tracking in social behavioral change practices in the community. So because the parenting program is based pretty much on SBC practice, so obviously it's not easy to track behavior change in a 4 years time when we are implementing the program, but it's a very good indicator to set, and also it's a very good conversation to start having when conducting the program with the community. So these are some of the area around the genders topic that we are included in our social behavior change indicator during the program. So we have, as I mentioned, we have care, protection, and communication. So this SBC indicators is actually around cares and also protections. And as you can see, there are different questions and different area where we explore. So we'll be able to track what has changed and what would create a discussion among the community. So these are just the example that we've been working with Lao women unions over the past 4 years. Obviously, when we're talking about social behavioral change, these are just the start. What we are expecting in the long run is to improve service delivery and also to do system strengthening so that in the long run, we would understand that Lao women union will take this approach and will be able to work with the community so that they will understand more and also implement this on a daily basis to have all discussions going on at the community level so that we hope that in the long run there will be change in behavior. So over for my slide. So I'll give the floor to Maria, please. Thank you. So these are just the example of what is going on in the field. So I'm sharing with you the photos. Thank you. Over to you, Maria.
Thank you very much, Kavi, for the insightful presentation. And from my side, I will share very briefly gender analysis of immunization that we are currently undertaking. So the objective will be for the findings of this gender analysis to inform the strengthening of this parenting program, but also of our other immunization programs that work on both increasing demand and also improving the delivery of immunization services, so both demand and supply. And this gender analysis of immunization is part of a regional initiative, which is led by UNICEF Regional Office and includes Laos, Philippines, Indonesia, and Mongolia. And the objective is to understand the gender-related barriers that impact immunization, namely childhood routine vaccinations, COVID-19 vaccinations, and HPV vaccinations. So it's taking a life course approach and not focusing only on early childhood development. And it utilizes a mixed method approach with both qualitative and quantitative methods and utilizing various data collection tools, including key informant interviews, focus group discussions, and surveys. And we really want this gender analysis to take an intersectional lens. As my colleague Kavi has mentioned, Lao is a very culturally diverse country, and the gender norms really vary from ethnic group to ethnic group. And so in this intersectional analysis, we want to understand how gender interacts with other factors such as culture, as I mentioned, geography. So we selected rural areas and urban areas, and also in terms of the delivery of immunization services. So we are comparing communities that have health facilities with communities with outreach services and communities with mobile services. Unfortunately, I will not be able to show the findings yet because they will be available only in July 2024. Next slide, please. So we develop several research questions, and here is just a selection across the social ecological model, the various levels from individual level up to policy and legislative level. Some examples, for example, for service delivery level, we want to understand better what are the specific needs of female workers that do outreach and mobile services, given that they have to spend the nights in another place. Do health providers know how to provide information that is understandable to the different target groups? And here I'm thinking of the adolescent parents, for example, or the adolescent girls related to the HPV vaccine. In terms of community dynamics, what are the gender and social norms influencing vaccine uptake and access, and how do they differ among ethnic groups? And for individual and household level, how do women, men, adolescent girls, and adolescent boys access health and immunization information? What are their preferred channels? And we are utilizing the 5 domain analysis framework, so looking at patterns of decision-making, access to and control over resources, roles and responsibilities, cultural norms, and also laws and policies. Next slide, please. Based on the findings of these analyses, we will invest in capacity building of government counterparts and mass organizations at all levels, from national level down to subnational levels, and then develop specific strategies to address each of the gender-related barriers that will be identified in these analyses. And also we want to move further. We don't want the program to be only gender responsive, but also gender transformative. So we will develop strategies to further transform discriminatory gender norms and empower women and girls. And finally, we will also strengthen the M&E framework of our other immunization programs so that they are able to track changes in gender-related barriers and gender norms transformation, as the parenting program is already doing. Thank you very much.
Thanks so much. And Tendai, over to you.
Thank you very much. I'm just going to put on my video briefly. Hello, everyone. Good morning, good afternoon, good evening, wherever you are. Unfortunately, I'm not going to have my video on for a long time, just due to internet connections this side. Okay, so I'm going to present to you about immunization in Zimbabwe, and as an organization, how we've managed to work with an ultra-conservative community in terms of supporting the government of Zimbabwe with immunization challenges which they've been having for a long time, and making sure that there is a positive response from those communities in terms of uptake of immunization. So our organization has been working with the government, and it was established in 2016 with the mandate to advance the rights of adolescents and women issues and mainstreaming of gender in apostolic church activities. OUT is fully cognizant and works with diverse apostolic churches who have different beliefs, norms, values, and perceptions on key social issues such as child marriage, education, HIV, MNC, GBV, and SRH. Next slide, please. So in terms of religion, I'm just going to talk briefly in terms of the religion of Zimbabwe. Like I said, we've been working with the ultra-conservative community. This is considered the zero-dose community, where there is no uptake in terms of immunization. So in terms of the religion of Zimbabwe, over 85% of Zimbabweans, which 74% of them are men and 93 women, of adult Zimbabweans aged between 15 to 49 identify themselves as Christian. So Zimbabwe is a Christian community. And from that Christian community, we've got our apostolic sect, which constitutes of the zero-dose community that I've been referring to. These are the majority in terms of the Zimbabwean population, which has 38% in terms of population of the Zimbabwean community, which I would really say it then takes about 6.8 to 7 million in terms of the population of Zimbabwe, making the Pentecostals and the Protestants and the Roman Catholic about 30, more than 30% being Christians, and the other remaining then are affiliated to the traditional and the Muslim community. Next slide, please. So in terms of the statistics, like I'd already given you, the apostolic community comprises of the 38%, which I've said that it's more than 6 million in terms of the population of Zimbabwe, and 73% of that population stays in the rural community, where we've got challenges in terms of immunization. And 64% of this community are women which are aged between the age of 20 to 29 years, and which are the childbearing age. And with the apostolic community, they've got different doctrine and practices. Mostly it's a polygamous community, and they believe more in spiritual healing than the medical healing or the modern Western medicines. They also pray outside where there's no water and little sanitation. And they've got diverse norms, beliefs, and perceptions and practices. Next slide. So we've got different groups in the apostolic community. We've got the ultra-conservative groups and we've got the semi-conservative groups. So with the ultra-conservative groups, this is where we really do target the zero dose community, where there is strict religious doctrine and practices. Social practices undermine gender equality. Young girls are married and pledged to older men in polygamous marriages, which expose them to a lot of health challenges. And there's also poverty within this community, and which undermines educational and socioeconomic opportunities. Hence, the challenges in terms of immunization uptake. We also have the semi-conservative groups. These are the moderate ones, where, of course, uptake of modern health services is there, but at the end of the day, they seek spiritual guidance first before they can be in a position to access modern medical services. Next slide. So we, as AWET, we believe in primary socialization, and we socialize any woman at the moment they conceive, during conception, up until the child is 10 years. We will continue to capacitate them in terms of socialization. So AWET intends to change the perception of how women are viewed, as we believe that domination comes as a result of patriarchy, which is a failed entity of socialization. Therefore, it is important to empower the women who will in turn socialize the child in a way that enables them to grow up viewing and giving women the respect they deserve. So we socialize any woman from conception up until the child is more than 10 years, because we believe at that time, if you socialize the child the way you would really want them to come up, they will learn from conception up until 10 years, and they can be the champions of immunization, which we really want to see in the future. Next slide. So in terms of our zero dose programs that we have been having in Zimbabwe, we've been complementing the government of Zimbabwe through working with the Ministry of Health and Childcare by mobilizing the hesitant communities to uptake health services, to uptake immunization. And we've been working in the zero dose communities. And as AWET, we have been working in each and every province in Zimbabwe. And with the zero dose program, we've been targeting 4 provinces where we had already identified the hesitance in terms of uptake of immunization, of vaccines. And we have been working in these provinces and up until to village level in terms of capacitating. I'll explain more in terms of the approaches that we've been using. And on the program, we've been focusing on immunization, and the emphasis has been on the zero dose communities, making sure that there is uptake of vaccines on polio, on measles, and also making sure that the under 5s are vaccinated. And the program tackled issues of harmful social norms that hinder communities from accessing health services through a tailored intervention through dialogues. And our primary targets were the apostolic community, especially the ultra-conservatives, the ones which I have been referring to as the zero-dose communities. Next slide. Our objectives were to make sure that in terms of our goal to enhance communities on resilience, on handling emergency situations and multi-hazard response through strengthening community up to ward and village levels in terms of our structures. And the objective was been to prevent morbidity, mortality, and disability related to vaccine preventable diseases, and to create awareness on the importance of vaccination and promote vaccine uptake among key groups and communities, and to prevent hygiene practices of people in order to prevent diarrheal diseases, especially now in Zimbabwe. There's been a lot of challenges due to cholera outbreaks, and to put up structures, care groups, which I'll talk about just now, and to build capacities of local communities through volunteers and responding to emergencies, and create demand for vaccination. Next slide. In terms of approaches, is what we've been working with the communities and also identifying women and women whom we work with within communities, especially from the ultra-conservatives, because that's where our main focus has been in terms of uptake of immunization. So we then capacitate them on social behavior change. And I think in that picture, you can see it's just one picture from one district, which is Mwenezi, and on immunization, and to spearhead the program within the districts. So the trainings in terms of capacitation, we conduct them together with Ministry of Health, UNICEF, and UNICEF, the SBC department, and making sure that within the structures for Ministry of Health in that community, we are also supported. Next slide. So we have our approach into this program, which we've been focusing on zero-dose communities. We have what we call the mentor mothers. And mentor mothers are capacitated, and when they are capacitated, they then offer integrated services within communities. So our mentor mothers play a pivotal role in zero-dose apostolic communities by providing support, guidance, and education to ensure the health and well-being of mothers and their children. So any a young mother or any new mother, they need that support, they need guidance. Long back, of course, would really know that they were, in terms of family support, there was a lot of family support, but nowadays, because people are very busy and in terms of focus and that support from families, sometimes it's not there. So the mentor mothers, they act in terms of giving support and guidance, especially with the new mothers. They also serve as role models and source of practical advice for other mothers in the communities. They share their own experiences, knowledge to help other apostolic women navigate the challenges of motherhood, such as prenatal care, breastfeeding, childcare practices. And the way the mentor mothers are selected, they are selected from the zero-dose community, because we want to see transformation within these communities through vaccination. So those who had been vaccinated, who had vaccinated their children, are the ones who are considered as mentor mothers, because they would be considered as champions within their communities in terms of health uptake. And mentor mothers, they help to create awareness about the importance of healthcare practices such as vaccination, antenatal care, SRH, MNCH, HIV and AIDS, education, nutrition. They work with community members to identify barriers, to change behavior and develop strategies to overcome them. Next slide. So in terms of mentor mothers, how they also support in terms of immunization, they play a crucial role in supporting mothers and their children on immunization. Due to poor health-seeking behaviors of the zero-dose communities on immunization, the mentor mothers then give guidance and educate the communities to ensure that there is health uptake and well-being of children. They also support in terms of making sure that there is an online nurse who is available for the community 24/7 in terms of support if they also need anything. And this is also supported by UNICEF, Ministry of Health, and also our mentor mothers support expecting mothers on educating them on the importance of vaccinating their children. They prepare the mother before the child is born on the vaccines up until 5 years. Mentor mothers support mothers, expecting mothers when a child is born until they reach 5 years. They help mothers to remember all the vaccines a child requires. They also encourage uptake of any EPIs that would be administered in their communities, so that they are not left out and there's no exclusion in terms of receiving any immunization within their communities. Next slide. Mentor mothers and ANC. Mentor mothers support pregnant women in accessing necessary care and pre and postnatal health information. They act as the bridge in terms of any gaps by closing the gulf between health facilities and apostolic communities, helping to increase awareness and uptake of ANC services. They also educate in terms of ANC, especially when there are also myths and misconceptions in terms of their pregnancy journey. And also their involvement has been proven to improve MNCH outcomes and contribute to overall well-being of the apostolic women and their families. And also they work together with the health workers and the ministry within the communities. Next slide. Mentor mothers and SRH. Like I said, this is a polygamous community, especially the zero-dose community, and they don't believe in uptake of modern health services. So they need support from mentor mothers in terms of making sure that they can be supported in terms of reproductive health services, and making sure that there is support, especially on contraceptives, making sure that they also have safe sex and STI prevention because of being in a polygamous marriages. Mentor mothers, they serve as role models and provide emotional support for women and girls navigating their SRH, and also provide information on the benefits and risks of different methods and help women make informed choices. Next slide. Mentor mothers and MNCH. This is also very important for mentor mothers as well. Like I'm talking about all this, it's integrated services. Like I said, there are integrated services, immunization and integrated services. And through MNCH, they make sure that they promote maternal, newborn, and child health in communities. They serve as a source of guidance and support, educating all the pregnant women and new mothers and families to prevent fistulas, eclampsia in expecting mothers. They provide education on MNCH and topics such as prenatal care, safe delivery, breastfeeding, nutrition, and child development. They also help women navigate health system access and necessary services, and understand how to care for themselves and their children. Next slide. Mental mothers, nutrition, and exclusive breastfeeding. Yes, this is also very important in terms of the integrated services which communities they've been having. They also provide education in terms of balanced diet, nutrition, making sure that there is exclusive breastfeeding up to 6 months as soon as their children are born, and making sure that whenever they are now feeding their children, whatever they are feeding them, it's also a balanced diet, and they don't suffer any malnutrition or any kwashiorkor in the process. Next slide. Mental mothers and HIV. I'm still on integrated services. Mental mothers, they support in terms of immunization, and also making sure that they promote HIV testing. And if they are not tested, they need to start early in terms of treatment. They remain on treatment. They monitor their viral load. They screen for any STIs, TB, and cancer. And also they practice safe sex using condoms. Next slide. These are just pictorials, which I'm just sharing. Yes, next slide. Next slide. Thank you very much.
Great. Thanks so much to our presenters for super interesting presentations. We still have like 5 minutes for to reply to some questions. Okay, let's see. So there is a question from Krishna Kumar to Tendai. What are the supply side barriers in the existing area of intervention? If you can reply to that, Tendai.
Yes.
Yeah.
Okay. Yes, thank you very much, Krishna, for that question. Like I mentioned that we already work with the ultra-conservative, where there is strict religious doctrine, and it's very strong in terms of how we then work with the communities. But we are very happy with the response and the support that we've been getting, especially from the leaders, because the leaders are the ones who are also now supporting us, so that the women are empowered. We get to work with the mentor mothers from that community in terms of making sure that the interventions are there, and we are able to work. But over and above, in terms of the barriers, yes, the barriers are still there because it's not a community where they would really want people from outside to come, because it's a closed community. So we really need to make sure that whenever we are getting into this community, we are getting into a community where we've got a lot of strategies, where we are bringing in services to the community, not for the community to go out and get services. So in terms of supply, yes, we definitely have to make in terms of makeshifts immunization structures within the communities so that there is access for the community.
Great,
Thank
thanks
you.
so much. And since you're here, this is a quick question. Maybe you can reply. Are they part of the zero dose community? I understand yes, but if you can just quickly reply to that, mentor mothers.
Yes, they are part of the community. Yes, they are
Yeah.
part of the community and they are part of the ultra-conservative community.
Yeah. I would like to also myself ask you something, but I see there are many questions and let me see. There was a question on the gender analysis report. I'm not sure if it does refer to the one presented by UNICEF, but I understand this report is going to, I mean, it has to happen, and so it's going to be disseminated in July. But maybe, Maria, I don't know if you want to take some of the questions that, I mean, there are many questions asking basically how gender influence access and utilization of immunization services. I don't know if you want to reply to that, one of that question.
Hi, Michelle. Perhaps I can answer the question about how gender intersects with the other factors. And I would say that it really depends on the country and the context. I can just give a few examples. In terms of how it intersects with language, we had a woman saying, in the village, the women usually stay at home while the men go out to work. Men have more opportunities to interact with outside world, and because of that, the men can often speak and understand Lao more than the women here. So if we would have men with more ability to speak in Lao language, and women would need communication in the local language, which is the ethnic language. So this is a gender gap that will influence the access to immunization service. This was an example. Another example related to age, we as children grow up, we understand that the gender gap widens during adolescence. And in some ethnic groups where there is a social norm says that child marriage is okay, this means that we will have a much higher child marriage rates, and so much more adolescent parents. And what the evidence also from Laos tells us is that adolescent parents tend to have much less likely to receive antenatal care, to deliver in health facilities, and also to access services for themselves or for their children. So this will, of course, also impact immunization rates. And here we have the intersection of gender with age and with ethnicity. So the intersections are multiple, and it really depends on the country context and the geography that we are working on.
Great. Thanks so much. And thanks, everyone. Unfortunately, we are at the end of the hour. We have to close this session. There are many questions in the chat. Tintais is doing her best also to reply, but also we're going to lose the interpreters, so we have to close. Please feel free to send your emails also by email or post them in the TechNet webpage. And so we're happy to reply if we were not able to reply now. We really thank you for joining this session. Thanks so much to TechNet for their support. Thanks to our presenters for their time and super interesting presentation. Thanks to Stephanie Chandal, she's the main organizer of this webinar series. And yeah, join us for the next one, which is going to be about how to apply a gender lens to research and innovation. So super interesting topic. Don't miss that one as well. So bye, everyone.
Thank you very much. Bye-bye. And just a quick reminder, every webinar materials is going to be sent by email to all who